In this segment, we're gonna discuss shock. Shock, what's the definition of shock? And if you say the definition of shock is low blood pressure, I'm gonna ask you, how low? Less than 100, less than 90, less than 80, how low? And besides, all types of shock are characterized by low blood pressure. So this is not gonna help. So shock is inadequate tissue perfusion. Again, I have to ask you, what do you mean by inadequate? How can we measure the inadequate? Inadequate tissue perfusion resulting in widespread impairment of cellular metabolism when you force the cells to do anaerobic metabolism. When you force the cells to do anaerobic metabolism. So shock is a blood pressure that is so low that it forces the cells that suffer from inadequate perfusion to do anaerobic metabolism. The blood pressure is very low, the tissues are inadequately perfused, and the cells within these tissues are forced to do anaerobic metabolism. Okay, I don't care if skin cells do anaerobic metabolism. I don't care if the GI cells do anaerobic metabolism, but I care about the tissues of 5 organs. We call them the 5 vital organs: brain, heart, lungs, liver, kidneys. Brain, heart, lungs, liver, kidneys. Brain, heart, lungs, liver, kidneys. The 4 vital organs, the 5 vital organs. If they do not get enough oxygen and their tissues are forced to do anaerobic metabolism, this is shock. This is shock. There are 3 categories of shock: hypovolemic, cardiogenic, and distributive. And let me use the whiteboard to talk about these 3 types. Let me draw this kind of pattern. If we have a reservoir here, and then here I'm going to put the heart. And then I'm going to put the arteries. And the arteries supply 2 types of organs: the non-vital and the vital. And by the way, the non-vital receive more arteries than the vital. Why? Non-vital, the 2 largest systems and organs in the body. The skin is the largest organ in the body, and the gut is the largest system. So these 2 non-vital organs receive a lot of blood supply, So if something happens with the reservoir and the amount of blood in the reservoir is low, so the venous return is low, the preload is low. If you bleed or if you are dehydrated, that's the first type of shock, and that's hypovolemic shock. So hypovolemic shock, the problem is in the reservoir, empty reservoir, low blood volume. If you have low blood volume, it's obvious that you're gonna have shock. The second type of shock is a cardiac problem. If you have severe heart failure, or if you have heart attack and your heart cannot pump. So we call this pump failure, or we call it cardiogenic shock. The third type of shock occurs here, at the point of distribution of blood between the vital organs and the non-vital organs. We can control the amount of blood going to a certain organ by controlling the diameter of blood vessels going to this organ. So, for example, when you exercise, the arteries going to the muscles dilate, and the muscles get more blood. Why do we get kind of sleepy and drowsy after eating heavy meal? Because more blood goes to the gut and your brain receives relatively less blood. So you tend to be kind of sleepy. In cold weather, we get vasoconstriction of the vessels going to the skin. Therefore, if something happens and disturbs this mechanism of distribution, and if all arteries suddenly dilate, the arteries going to the non-vital organs and the arteries going to the vital organs, if all the vascular bed dilates suddenly, what's going to happen? There will be maldistribution. If all arteries are dilated, which organs will receive more blood? The vital or the non-vital? The non-vital. Why? Simply because they have more number of arteries, simply because they are larger. So we call this type of shock, we call it distributive shock. So hypovolemic shock, that's the easiest. It results from hypovolemia, bleeding or dehydration. Cardiogenic shock, that's pretty straightforward. Weak heart, pumping action is lost. Distributive shock results from widespread arterial dilation with redistribution or maldistribution of blood. The majority of blood goes to the non-vital organs, so the vital organs will be inadequately perfused to the extent that they are forced to do anaerobic metabolism, and this is shock. Let me get back to the PowerPoint. So hypovolemic shock due to hemorrhage or dehydration, cardiogenic shock due to pump failure secondary to heart attack, MI, or severe decompensated heart failure, distributive shock due to arteriolar dilatation and drop of the systemic vascular resistance. What can do this? Neurogenic. If you have failure of the sympathetic nervous system, it is the sympathetic nervous system that keeps the arteries partially constricted. That's why it's maintaining your blood pressure. But if you have spinal cord injury and you lose the sympathetic outflow, to the blood vessels dilate. Or if you take drugs, some medications. Anaphylactic shock. Anaphylactic shock will result in widespread sudden release of histamine all over the body from all mast cells all over the body, and you get massive vasodilation, okay? Septic shock. If you remember, we discussed the mechanism of septic shock, and the activated neutrophils, they attack the endothelium of the arteries, liberating nitric oxide, and this results in arterial dilatation. And this will cause distributive shock because now the blood will shift to the non-vital organs. So if we want to compare the three types of shock regarding these different variables: cardiac output, heart rate, systemic vascular resistance, ejection fraction, pulmonary capillary wedge pressure, which is a surrogate of the left side pressure, the pressure in the left side, jugular venous pressure, which is a surrogate of the right ventricular pressure. So pulmonary capillary wedge pressure reflects the left ventricular pressure. Jugular venous pressure reflects the right ventricular pressure. And here we have, of course, the blood pressure and skin temperature. To begin with, what's common among the three types of shock: hypovolemic, cardiogenic, and distributive, and we're taking septic shock as one example of distributive shock. What's common among all three types of shock is the low blood pressure. So this is not going to help you. So the blood pressure is not going to tell you the type of shock. Now, septic shock is unique in some features. Septic shock is the only shock because of the mechanism of distributive shock, arterial dilatation. And when the arteries dilate, the skin will receive a lot of blood, and the skin temperature will be warm. So that's one unique thing about distributive shock or septic shock: warm skin. All other types of shock, you get cold skin. The second characteristic thing about septic shock, and this is basically the mechanism of distributive shock, is the low systemic vascular resistance. Low systemic vascular resistance. So septic shock is kind of easy to detect, and usually there is either suspicion or indication of infection, and the patient is not responsive to crystalloids, so this is enough to diagnose septic shock. Okay, hypovolemic and cardiogenic. It happens, it's not uncommon to face this scenario. An elderly patient comes to the ER referred from a skilled nursing facility with shock, very low blood pressure, oliguria. Obviously, he is in a state of shock. This shock could be in elderly. It could be dehydration, because elderly very easily can go into dehydration. And it could be decompensated heart failure, because this patient is known to have heart failure. So how to tell them apart? Is it hypovolemia or cardiogenic shock? Because you know what? The management of one type can kill the patient if he is wrongly diagnosed. For example, if it is hypovolemic shock, what are you going to do? Infuse normal saline. Imagine if you give 2 or 3 liters of saline to a patient with decompensated heart failure. This is going to kill them. Okay? That's why there is one simple single trick that will help you diagnose and get the difference between hypovolemic shock and cardiogenic shock. Look at the neck veins. Look at the jugular venous pressure. If the neck veins are collapsed, if the jugular venous pressure is low, that's hypovolemic shock. Give them normal saline. But if the jugular venous pressure is elevated, that's cardiogenic shock. Okay, the standard neck veins. So the cardiac output is low in hypovolemic and cardiogenic. It's elevated in septic shock because of the hyperdynamic state. In all cases of shock, the sympathetic nervous system is stimulated. So the heart rate goes up and the ejection fraction goes up. But of course, in cardiogenic shock, the ejection fraction goes down. And the sympathetic will cause cutaneous vasoconstriction. That's why the skin temperature is cold. It goes down in hypovolemic and cardiogenic. But of course, because of arterial dilatation, the skin temperature is elevated in septic shock. In hypovolemic, because there is no blood, there is no enough blood, so the pressure in the right side and on the left side is low. So the pulmonary capillary wedge pressure is low and the jugular venous pressure is low, simply because the blood volume is low. But in cardiogenic shock, the left-sided pressure is elevated and this causes pulmonary congestion, and the right-sided pressure is elevated and this causes jugular venous pressure to increase as well. So use the jugular venous pressure to differentiate between hypovolemic shock and cardiogenic shock. The distributive shock, like for example, septic shock, is the only type where the skin feels warm due to peripheral vasodilation. And this finishes the discussion of ischemic heart disease and shock. And this is the last segment on the cardiovascular disorders.